my YouTube channel Harrison Learns, where we dive deep into fascinating and sometimes scary world of medicine. Today I am going to explain interstitial lung disease or ILD for short. Imagine your lungs as a pair of soft, spongy balloons that effortlessly fills with air. Now picture those balloons turning rigid, scarred and inflamed. That's ILD in a nutshell. It's not just one disease, it's a group of over 200 conditions that can turn breathing into a battle. Now, let's dive into the topic. First off, what exactly is interstitial lung disease? It is diffuse parenchymal lung disease, meaning it affects the tissue around your lungs. Think of interstitium as supportive framework around your air sacs. When it gets scarred and inflamed, then it leads to pulmonary fibrosis. This damages and thickens your lung walls, making gas exchange way harder. It leads to reduced pulmonary gas exchange. It affects millions worldwide, with incidence rising in older adults. A fun fact: the term interstitial comes from the space between cells. It's like the grout in your lung style work getting messed up. Then, what are the symptoms? Progressive dyspnea, shortness of breath with exertion, dry cough that just won't quit, no phlegm, no fun. Imagine climbing the stairs and feeling like you're climbing Mount Everest. That's the daily reality for many with ILD. Moving to diagnosis. PFT, pulmonary function test, are key. You will see reduced total lung capacity, decreased diffusing capacity for carbon monoxide. That's how well your lungs transfer gas. And normal or reduced FEV1 and FEC, indicating restrictive lung disease. The diagnosis approach always starts with HRCT, which is high resolution CT. It's like a super detailed x-ray of your lungs. If needed, you have to do bronchoscopy for specific ILD diagnosis or even surgical lung biopsy. Then ILD is classified into known cause and unknown cause. In known cause, it is related to exposure and systemic disease. And in unknown cause, there is idiopathic interstitial pneumonias and other causes. Let's dive deep into the topics. Let's dive into idiopathic interstitial patterns, the mysterious ones without a clear cause. First up, idiopathic pulmonary fibrosis, which is most common in 5th or 6th decade of life. Most common in men than women, often with a history of smoking or environmental exposures. What do HRCT show? It shows UIP pattern. Remember, this is very important. UIP means usual interstitial pneumonia pattern. In this, there will be subpleural reticulation with post-basal predominance, which is nothing but netting like patterns at lung bases. And there will be traction bronchiectasis, which is stretched airways, and honeycombing, which are like little cysts in the lungs. And what do histopathology shows? It shows UIP pattern with fibroblast foci, temporal and spatial heterogeneity, meaning the scarring is patchy and at different stages. You can see here there is traction bronchiectasis, which is stretched airways, and there is honeycombing, and there is reticular airways. Treatment is antifibrotic therapy like pirfenidone and nintedanib to slow it down, and we can give oxygen therapy in severe cases and lung transplant for eligible patients. And one more thing I want to add is genetic factors like MUC5B gene mutations also increase risk. It's not all about environment also. Next one is non-specific interstitial pneumonia, which is NSIP. It occurs in non-smoking females in their 5th decade of life, and it is often associated with connective tissue disease like rheumatoid arthritis. What does HRCT show? It shows NSIP pattern. In this, you can see diffuse subpleural symmetric. Remember, symmetric ground glass and reticular opacities, and there will be occasional subpleural sparing, and there will be traction bronchiectasis This you can see in this image. There is subpleural sparing, there is reticular opacities, and there is ground glass opacity. What do histopathology show? It shows uniform appearance of inflammation and fibrosis. There can be two types, predominantly cellular and fibrotic. And what is a treatment? Treatment is oral steroids like prednisone and cytotoxic agent like azithromycin and mycophenolate, and biologics like rituximab. Remember, NSIP has more favorable prognosis than idiopathic pulmonary fibrosis, and fibrotic is always refractory to treatment, unlike cellular type. Next is smoking related interstitial lung disease. You have to think about respiratory bronchiolitis and desquamative interstitial pneumonia. They affect heavy smokers between 40 and 50 years with dyspnea and cough. What do HRCT show? It shows central bronchial wall thickening and peripheral bronchial wall thickening. It also shows centrilobular nodules and ground glass opacities which are bilateral and symmetric. What do histopathology show? They show pigmented macrophages within lumen of bronchioles, and there will be bronchiolar alveolar fibrosis which are patchy and confined to peribronchial region. There will be prominent interstitial thickening. This whole thing is DIP pattern. What is treatment? Treatment is you have to quit smoking. Obviously, it's a game changer. Next is cryptogenic organizing pneumonia. It affects between 50 to 60 years old persons, and it is subacute flu-like illness. What do HRCT shows? It shows patchy consolidate opacities often associated with ground glass opacities, and there will be reverse halo or atoll sign like a ring of consolidation. Okay, like a ring of consolidation. What do histopathology show? It shows granulation tissue with surrounding inflammation. What is a treatment? Treatment is corticosteroids. And this COP can mimic pneumonia. Okay, this COP can mimic pneumonia or cancer on scans. So that's the reason biopsy is crucial. Relapse is common if steroids are tapered too fast, but overall good prognosis with 90% response rate. Acute or subacute ILDs. In this, we are going to learn about acute interstitial pneumonia, which is also known as Hamman-Rich syndrome. In this, we can see acute onset of respiratory distress and hypoxemia. This is rare but often fatal. In HRCT, we can see patchy bilateral ground glass opacities. And in histopath, we can see diffuse alveolar damage. This is very important. Remember this, diffuse alveolar damage. Treatment is mostly supportive and you can give mechanical ventilation to the patients. AIP is like ARDS, mortality up to 50%, no specific therapy, but early ECMO can save lives in young patients. We are going to learn about ILD associated with connective tissue disease. ILD often complicates connective tissue disease. In systemic sclerosis, HRCT may show NSIP or IPF pattern with cryptogenic organizing pneumonia, and diffuse alveolar damage also may present. Treatment includes cyclophosphamide. And in rheumatoid arthritis, the ILD is most common extra-articular complication. The HRCT may show UIP pattern, which is most common. It can also show NSIP also. Management uses immunosuppressive and cytotoxic agent. In granulomatous ILDs, the most common one is sarcoidosis. Next is hypersensitive pneumonitis. It is a granulomatous reaction due to inhalation of organic or inorganic dust. In granulomatous vasculitides, there will be blood vessels with inflammatory infiltrates and associated granulomatous lesions, and hemoptysis will be presenting symptom. Taken from Harrison, which summarizes everything I discussed before about common interstitial lung disease findings. That includes about clinical symptoms, physical exam findings, exposures, HRCT findings, histopathology, clinical course about idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, respiratory bronchiolitis associated ILD, which comes under smoking associated ILD, and systemic sclerosis associated ILD, and sarcoidosis. Once go through this table, it is very important. This summarizes literally everything. If you have any doubts, please comment. If you like my video, please like and share my video and subscribe my channel. Thank you so much.